my name is Skylar Landis. I am a family nurse practitioner student at West Texas A&M University. I am completing a comprehensive head-to-toe assessment on a 47-year-old female. Before we begin, I'm going to show the camera around the room. Okay. Prior to the exam, we completed a general survey of the patient's past medical history, surgical history, social history, allergies. The patient has no known drug allergies, and any medication she currently takes. She only takes a daily multivitamin. We have obtained the patient's height and weight and vital signs. They were all within normal limits for the patient's age and height. And then we also assessed the optic nerve, cranial nerve number 2, which is, with the Snellen chart, the patient's visual acuity was 20/20 bilaterally. And then we, during the assessment with the general survey, the patient is alert oriented times person, place, time, and situation. She is appropriate neurologically and is a good resource for information. I have washed my hands. I'm now going to begin the head and facial inspection. We're looking for symmetry, making sure the temperature and color of the face and head are appropriate. We're looking for any lesions, making sure the distribution of the hair is appropriate, that the scalp is not dry, checking for any nodules, masses, any tenderness, and it is appropriate. We're going to assess the temporal pulses. They are 2+ bilaterally. Checking the frontal sinuses and maxillary sinuses. Again, looking at the face, making sure the color and temperature is appropriate. We do have a small freckle to the left of the face. We will then move to the trigeminal nerve, cranial nerve number 5. If you'll just tell me if this is dull or sharp.
Dull, sharp, dull, sharp.
Okay. Next, we are going to move to the patient's eyes. If you will look at the wall for me, pupils are at 4 millimeters in size, and then if you'll keep looking at the wall, I'm going to shine a light in there. Direct, consensual, direct, and consensual. Then look at the pen light, and then the wall, pen light, and then the wall. Okay. Pupils are equal, round, and reactive and accommodate to light. We are also looking at the cornea, iris, and the lens, making sure there are no opacities there. We're also looking at the sclera, making sure it's nice and white, and the conjunctiva, making sure it's nice and pink. Yellowing of those are signs of liver disease or dehydration. We are then going to assess cranial nerve number 3, 4, and 6, making sure, or assessing the ocular motor, the trochlear, and the abducens nerves with the 6 fields of gaze. Follow my pen. Good. Visual acuity is appropriate. And then next we are going to assess the optic disc, making sure that the margins are nice and sharp on it as well, with the red reflex. With this, we are looking for any signs of papillary edema, hemorrhages, or exudates. We're also looking at the same eye that we are assessing. I am needing to assess it with my same eye, making sure that we are balancing our hand on the head, keeping it nice and still. With her optic disc, it was nice and sharp, no signs of those abnormalities. Next, we are going to be assessing the ears. First, we will inspect the external parts with the auricle and the tragus and the mastoid, making sure there's no tenderness, swelling, or redness, or any drainage. We will then inspect the inner ear, pulling the ear up and back for adults, moving it down and back for pediatrics, making sure there is minimal amounts of ceramin, The cone of light on the left side for this patient was at 7 o'clock, and the tympanic membrane was nice and pearly gray, which is a normal finding. Again, we're going to pull up and back to assess the tympanic membrane. Nice and pearly gray, minimal amounts of cerumen. The cone of light on the right side is at 5 o'clock. Next, we are going to assess the cranial nerve number 8, the acoustic nerve, with the whisper test. If you'll repeat after me. 7,
7,
5.
5.
Next, we are going to conduct the Weber and Rhine test. The Weber test tests for lateralization. If you'll just tell me if this is equal on both sides. Next is going to be the Rhine test. We're looking for a 2-to-1 conduction from air to bone. If you'll just tell me when you stop feeling the air both times after I move it. Next, we are going to be inspecting the lips, mouth, and throat. With the lips, you just want to make sure that you are looking for any signs of redness, swelling, dryness, cracking. The patients seem well hydrated. They are symmetrical. No signs of edema or irregularities there. We're going to be assessing cranial nerve 7, 9, 10, and 12 with this patient. With 7, we'll have the patient smile. That is the facial nerve, and puff out her cheeks. Again, the facial nerve. Then cranial nerve number 9 is the the glossopharyngeal reflex, which is also known as the gag reflex. And then cranial nerve number 10 is also known as the vagus nerve, where you stick out your tongue and say ah. With that, you can also look at the patient's uvula, making sure it's nice and midline and pink, no signs of swelling. Next is cranial nerve number 10, which is when you will have the patient just stick out their tongue. Okay, and I'll have you open back up. Just going to look around at the teeth and the oral mucosa, making sure it's nice and pink, no signs of dental cavities, lifting up the tongue, making sure that the vascularization is within normal limits. We are then going to go ahead and finish the cranial nerves with cranial nerve number 12, the spinal accessory, pushing the shoulders up against my hands. Good. Next, we are going, are going to have assess the patient's neck, making sure the trachea is nice and midline, no deviation. If you'll swallow for me. We are unable to palpate the thyroid, making sure there's no signs of a goiter, mass, or nodules, or any signs of thyroid disease. We'll then, again, always assessing for any signs of edema, redness, swelling. We're going to have check the patient's range of motion with her neck, turning her head to the side, and then to the other side, and then up, and down. And then if you'll push your hand against neck against my hand. And then next, we are going to be assessing the patient's posterior thorax while the patient turn around. Okay. Beginning this inspection, we want to make sure the patient is not having any trouble breathing, no signs of accessory use of accessory muscles like in the shoulders or the lower abdomen. Patient is not tachypnic, showing no signs of respiratory distress. We are going to begin by feeling for any tactical firmitus. Say 99.
99.
99.
99.
99. Then we're going to assess for the costovertebral angle tenderness, for any kidney tenderness. Any tender? Then we are going to percuss the lung sounds, making sure that there is no hyperresonance. This could be signs of overinflated lung. If it is dull, it could be signs of fluid. Next, we are going to auscultate the lung sounds. We'll also auscultate after for any bronchophy, agophony, and whisper pectoraloquy. Take a deep breath. Again. Again. And again. And again. And again. And again. And again. And last time. Okay, and then say 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. Okay. With the excuse me, with the bronchophony, sorry. If there are any, if you are able to hear 99 clearly, it can be signs of consolidation due to pneumonia. Then we're going to assess the diaphragm. If you will take a deep breath, and diaphragm excursion is what I'm assessing. And exhale and hold it. You're looking for the dullness, and then you'll note where that is, and then we'll do again one more time, and then you'll measure that for the diaphragm. Next, we're going to have the patient turn back around. Then we're going to assess the patient's olfactory nerve, which is cranial nerve number 1. You'll close your eyes and tell me what you're smelling. Breathe in.
Alcohol.
In.
Alcohol.
Good. Again, we're looking for any asymmetry in the nose, making sure there's no septal deviation. Take a deep breath in and in. Good. We're going to be looking in the inside, making sure the nares are patent, small amounts of mucus present. The nares are patent. Mucosa is nice and pink. No, not mucus. Okay. Next, we are going to be going over the axilla as well as the lymph nodes. So with the lymph nodes, we're going to start with the preauricle, postauricle, submandibular, submental, cervical, postcervical, and supraclavicular. With the supraclavicular, you want to make sure that you are not having any swelling there, because it could be signs that you have the patient has abdominal cancer that has metastasized to the lymph nodes. Next, we're going to assess the axillary lymph nodes, making sure there's no pain or swelling or tenderness. Next, we'll discuss examining the breasts and axilla. To do so, for the woman, you will examine in 4 different views. First, it will be arms to the side, arms up, arms at the hips, and lean forward. You're assessing symmetry when comparing the two, making sure there's no redness, tenderness, or swelling in either one. Then you will begin your palpating exam with light, medium, and deep pressure. You will begin from the clavicle to the bra line in a vertical motion with concentric circles going down. And then once you make it to the bra line, you will then go from the sternal angle to the posterior axillary. Again, making sure there are nice vertical concentric circles. You're assessing the axilla for any rash, irritation. You're assessing also the areolas, looking for any signs of redness, irritation, cracking. If there are any white patches there, it could be due to breastfeeding. If she is currently breastfeeding, it could be due to thrush. With the male breast examination, it is similar. You're still going to be completing the palpation. You're going to be assessing the areolas, making sure that they are not enlarged or asymmetrical with any redness, tenderness, looking for any nodules or palpable masses that could be moved, could indicate breast cancer. And then next we are going to assess the anterior thorax. Again, looking for any issues with breathing. The patient is not tachypnic. She is not using any signs of accessory muscles in her shoulders or abdomen. She is not showing any muscle retractions. You want to make sure that to inspect for any heaves or thrills. And while you're doing this, you can also assess for the tactical firmitus. Make sure those vibrations. You're assessing this with the palm of your hand and the pads of your fingers. While you're in this position, I'll have you lean forward and we'll feel the point of maximum impulse. Next we're going to percuss, again looking for the hyperresonant sounds or dullness, depending on whether they're overinflated or filled with fluid. Okay. Next we are going to assess the patient's lung sounds and heart sounds. Looking for any signs of adventitious sounds, deep breath, like wails, crackles, hoarseness, wheezing. And assessing lateral breath sounds. Now we're going to move on to the heart sounds, starting with the aortic valve at the second intercostal space. Pulmonary valve at the aorta was the right, the second intercostal space. The pulmonary is the left second intercostal space. Moving down to Herb's point at the third intercostal space on the left side. And the tricuspid valve at the fourth intercostal space. And then the mitral valve at the mid-clavicular line at the fifth intercostal space, having the patient lean a little bit forward, making sure that apex is as anterior as possible. Okay. While we're also assessing this, we can also go ahead and palpate the carotid pulses. And then assess for any carotid bruits, which could be a whooshing sound, which is a sign of stenosis. Next, we are going to assess the jugular venous pressure. Have you lay down on your back. Patient will be at 30 degrees with her head slightly tilted to the left side, able to view the meniscus and the suprasternal angle. We will be placing the ruler in the suprasternal angle and finding the highest point where you are able to pulsate the internal jugular, able to visualize the pulsation. And at that point, be 2 centimeters. For example, if this patient were to have a JVP greater than 4 centimeters, it could be due to fluid volume overload due to congestive heart failure. We're going to have the patient move down to assess the abdomen. First, we're going to be inspecting for any abnormal pulsations, peristalsis, any bruising around the umbilicus, any ascites, yellowing of the skin tone, again could be a sign of liver disease. Making sure that is normal in temperature and color. You're first going to auscultate the bowel sounds in all 4 quadrants. You always want to make sure you auscultate first, making sure that you don't damage your results due to palpating first and hyping up the bowel sounds. I'm then going to assess the abdominal aortic artery for any stenosis or bruits, signs of whooshing. And then we're going to do the same in the femoral arteries, again looking for that whooshing noise for a bruit. Next, I'm going to percuss the abdomen, looking for tympany, signs of organs. We're gonna move to the right of the umbilicus. We're gonna move up. Once we feel dullness, that is where the bottom of our liver will be. And then we'll move up and move down. And that is where our liver span will be measured. We'll move over to the left side, assessing for dullness for the spleen. Okay. Next, we're going to begin with light palpation, making sure there is no tenderness or irritation with that. Next, we will begin with deep palpation to assess organs. Next, we'll deep palpate for the liver. Take a deep breath and exhale. Making sure the margins are nice and soft. And then we'll palpate for the spleen. Okay. And then we'll palpate for both kidneys, making sure there's no signs of kidney infection. Deep breath. If there is, it could be could show as tenderness in those areas. Next, we're going to move down to the feet, assessing the plantar and dorsiflexion reflexes. First, we'll do the dorsiflexion, pull against my hands, and then push against my hands. Good. Going to assess the dorsalis pedis pulses, posterior tibial pulses, okay, as well as the popliteal pulses. And we'll assess the brachial pulses and the radial pulses. Okay. Next, we are going to assess the range of motion of the hips, first with flexion, extension, abduction, adduction, internal rotation, external rotation. Same with this leg, flexion, extension, abduction, adduction, internal rotation, external rotation. Next is going to be the knee range of motion, flexion, extension, internal rotation, external rotation, flexion, extension, internal rotation, external rotation. With this, we're also going to be assessing all four extremities, making sure that there are no signs of any abnormal hair distribution, normal color for ethnicity, no edema, redness in the shins or calves, could be signs of arterial insufficiency. Pulses on all sites were 2+ at amplitude. Next, we are going to have the patient sit up. Okay, we're going to assess range of motion of the shoulders with abduction, adduction. Okay, we're going to bring our arms down to here. If you'll pull towards me, good, and grip your hands as hard as you can. Good, testing strength, grip strength. We're going to test cerebral function with supinate and pronate, and then go as fast as you can. Okay. Next, we are going to have the patient close her eyes, and we're going to draw in her hands, assess, and just tell me what I'm drawing. What number I'm drawing, sorry.
7.
Yep. And if you'll tell me what type of item this is.
Tissue.
Perfect. Next, we are going to assess our reflexes, making sure, first we're going to test the tricep, and then the bicep, brachioradialis, and then the tricep, and then the bicep, brachioradialis, and then the patellar reflexes. And And then we're also going to assess the Achilles reflex. Okay. Next, we're going to assess your. We're going to have the patient touch finger to the nose, looking for any ataxia, with your eyes closed, whichever one I touch. Okay. And then we're going to assess for ataxia on the legs by having you rub your heel up and down your shin, and then the opposite. And then we're going to assess proprioception. You'll look at the wall and tell me which way I'm moving your toe.
Up, down. Up, down.
Okay. Next, we are going to have you stand up. Close your eyes. Okay, patient is balanced, testing the Romberg test. Now we're going to walk heel to toe to the carpet, assessing patient's gait and any ataxias, balance, and strength, and walk back on your tippy toes. Very good. Have a seat. Next, we are going to be discussing the male genital exam. This will begin with the patient laying in the left side, on his left side, in the lateral recumbent position. In doing so, we will begin assessing the sacrococcygeal and perianal areas, making sure that there are no lesions or abnormal nodules or breakdown in the skin. We will also be assessing the sphincter tone when we begin inserting our digits into them, making sure that we are going clockwise up all as far as we can to the right, assessing for any lesions, tenderness, nodules, abnormal drainage or bleeding, and then we will come back down counterclockwise to find the U-shaped prostate gland, making sure that we are assessing both lateral lobes and finding the median sulcus, making sure that the size, shape, contour, there are no lesions or tenderness on it. And then after that, we will move on to the female genital exam. Prior to that, we will have the patient empty out her bladder to make sure she is as comfortable as possible. We will have her move into the lithotomy position, have her draped from abdomen to knee, and then we will, excuse me, first be going over all of the steps in examining her external and internal vaginally, and as well as the bimanual exam and the rectal exam, and get her consent on all of those procedures. When beginning the external vaginal exam, we will be assessing the mons pubis, the labia, and perineum. We will then open up the labia and assess the labia minora, the clitoris, and the urethral medius, as well as the vaginal wall. Once we are completed with that process, we will assess which speculum to use on this patient, making sure we have the appropriate size. Again, going over each step with her, making sure she is comfortable with all of it, not having any abnormal amounts of pain. When inserting the speculum, we will open the patient's labia as wide as possible, inserting the speculum in a downward position and moving it horizontally, making sure that we are going nice and slow, making it, again, as comfortable as we can. In this time, we are assessing, once we have the speculum completely in, we will slowly open the speculum to assess the cervix, making sure that the wall is free of any polyps, nodules, exudates, any signs of abnormal drainage or bleeding. We will then insert the type of tool that is specific to the speculum, whether it is a broom, scrape, or brush. Insert it slowly and move in a circular motion around the cervix, and then slowly pull the tool out once we have received our specimen. And then after that, we will then begin to slowly remove the speculum. While we are doing this, we are assessing the vaginal walls. Once we are clear of the cervix, we will then remove the thumb screw and hold onto it manually as to make sure we do not pinch the cervix. As we are removing, like I said, we are assessing for any lesions, polyps, abnormal color, or drainage in the vaginal wall. Once we have removed the speculum, we will then move on to the digital rectal exam, again in the same position, in the lithotomy position, in the same manner as we would have on a male. We will then begin the bimanual exam after the digital rectal exam, assessing for any nodules, masses, any pelvic tenderness, as well as any masses we were unable to palpate because of how inferior they were compared to the digital rectal exam. After that, I will return to the male genital exam to examine the penis and scrotum. For that, we will be assessing the penile area, making sure it is midline, non-inflamed, no signs of redness, lesions, ulcerations, as well as making sure the urethra is midline as well. Assessing the scrotum anteriorly and lifting it up posteriorly as to make sure, again, any signs of nodules, asymmetry, lesions, ulcerations, redness or tenderness or swelling. We will then palpate each testis, making sure they are symmetric in size, shape, and mobility, assessing the spermatic cord, and then again making sure that we are assessing the epidermis for any signs of irregular size, shape, or swelling, tenderness. That is the completion of my comprehensive head-to-toe assessment. Thank you so much.